Hello everyone. In this video, I shall be talking to you about a very common necessity in clinical urological practice, which is about removing the Foley urethral catheter. And we will divide this topic into three parts. The first video will touch about what all should you keep in your mind before you actually remove the Foley catheter from the urethra. And I want you to evolve some kind of a pre-catheter removal checklist. What this checklist should comprise of. This is about obtaining information about three critical areas. Number 1, related to the catheter. Number 2, related to the patient as a whole. And number 3, some general details about the whole matter. What I want you to find out about the catheter in particular. Again, there are three issues here. Firstly, what was the reason for which the catheter was inserted in that patient? Secondly, was any special technique used to insert the catheter? And third, how long has the catheter been in place? Now, I consider these points, 3 points about the catheter of cardinal importance. And I'll explain to you each of them a little bit more. Talking about the first area about which you should seek the information from the patient directly or his caregivers or from his medical records. And if you do not have these from the records, do not hesitate in calling his doctor. There are many situations in clinical practice because of which the catheter is placed in. And according to each situation, the timing of removal of catheter or the precautions required at the time of removal catheter are influenced. Let me explain this. Commonest reason to place a catheter is to manage acute urinary retention. If it is BPH related AUR, then the catheter is usually removed after 3 to 5 days. If it is post anesthesia related AUR, the catheter is removed probably within a day or two. But if it is for a neurogenic disease related AUR, then the catheter is kept in for little longer duration, maybe 2 weeks, 3 weeks, 4 weeks. The second urological situation is to manage chronic urinary retention. Now, a number of patients with chronic urinary retention will have bilateral hydrouretal nephrosis with or without renal failure. If a patient has low pressure chronic retention, where there is no hydrouretal nephrosis, just the retention, here the duration of catheter can be shorter. But if there is associated bilateral hydrouretal nephrosis, duration of catheterization will be slightly long. In case there is a renal failure, it may be close to 10 days even. The third clinical situation is to manage bladder infection. There are patients in our practice where patients have large post-void residual urinary volume which gets infected. Now, to drain this infected urine, a patient is catheterized. Here, you must note that until and unless the infection is appropriately eradicated, the catheter cannot be removed. The fourth situation is to manage hematuria originating from urinary bladder, and often patients present here as clot retention and catheter is put in. You will notice very often that the urine draining out from the catheter will be clear in a day or two, and patient may insist that remove my catheter. But if you are going to remove the catheter in this patient, you must make sure that there are no residual clots in the urinary bladder, because these clots will lead to retention again. Prior to catheter removal, a check ultrasonography is required. The fourth situation is the catheter is put to facilitate healing of any surgical procedure that is done on urinary bladder, or prostate or urethra. Now here, please never remove the catheter without talking to the surgeon, because he only knows how nice was the surgery and what is his expectation about the healing time. This varies hugely from case to case. So, if you see here, these five situations, which are very common indications of placing the catheter, in each indication, duration of catheter indwelling changes, and you will have to verify that the reason for which the catheter was put in has been appropriately rectified. The second information about the catheter that you must find out is, was any special technique used to insert the catheter? The reason I'm asking you to know is that suppose in that patient the catheter was passed after dilating the stricture and a guide wire was placed in, and over the guide wire catheter was placed in. Now you want to remove the catheter. Suppose after removing the catheter, patient goes into urinary retention again, and now it is your responsibility to reinsert the catheter, and you do not have adequate equipment or you do not have adequate backing of theater, and you are not trained to place catheter by using these techniques. So before you put yourself in a trap situation, you know better what actually happened when the catheter was put in. The second situation may be that instead of a guide wire technique, or a urologist who placed the catheter used endoscopic guidance to place the catheter. And this happens when somebody else attempted to pass a catheter, a urethral trauma occurred, and now the catheter is not going in. In this setting, the doctor uses cystoscopic guidance to know where is the true passage and then place the catheter. And now when you remove the catheter of such a patient, you have to first verify that traumatized urethra is adequately healed. How will you know this? So it is better that again you talk to the person who at the first place placed the catheter in the bladder. The third thing that you need to know about the catheter is that in that particular patient, how long the catheter has been in place. What is the implication of this information? The implication is that if the catheter has been indwelling for only 1 week or less than a week, then you can very easily deflate the balloon and remove the catheter. But if the catheter has been inside for about 3 weeks or 4 weeks, then you can expect in some patients the balloon channel may be blocked and you will not be able to deflate the balloon. So you should be mentally prepared and be ready to use the methods to deflate the balloon. Or if you do not know them, you should have a senior assistant with you available. Then there are situations like a forgotten catheter, where patient, because of some mental illness or absence of caregivers, or he could not be transported to the hospital, or he was in coma for a long time and people forgot that he's on catheter. So there are many clinical reasons because of which catheter may be forgotten for long duration. And the tip of these catheters or the balloon of these catheters often gets encrusted. A tip becomes very rough. And even if you deflate the balloon, the encrusted tip cannot be pulled out of the bladder. So you may find it difficult. So you be alert, be ready when you're removing a forgotten catheter to face these situations. The fourth reason may be that there's a patient who is coming to you for a kind of catheter change. He has been on catheter for, let's say, 6 months or 2 years, 3 years. He visits you to get the catheter removed and after some time get the catheter reinserted. Now, when you are removing catheter in such situation, please be aware that these patients have chronic bacteriuria. So you should remove the catheter and at the earliest opportunity reinsert the catheter. If the time in between increases by few hours, then patient can get clinically symptomatic serious urinary infection. And I have seen some patients going in urosepsis because in between time was about 6 hours. Then you should know something about the patient. And this is First thing is, does the patient has diabetes? Because this I consider very, very important. It is such a common thing nowadays. Is there a diabetes? Or if yes, is it well controlled? Second thing you should know, at this particular point of time, when you're going to remove the catheter, is there a bladder infection? And third thing you should know is that in that particular patient, is there any systemic disease or a localized urological disease which predisposes this patient for symptomatic urinary infection? And let me elaborate these points one by one. Firstly, does the patient has diabetes? Now, if the patient has uncontrolled diabetes, you know that risk of recurrence of febrile urinary tract infection is huge. So, please just check the blood sugar of the patient before you pull out the catheter. And second thing, that even if the sugar is controlled properly, check that on which medication sugar is controlled. Nowadays, a large number of patients are taking SGLT2 inhibitors, which increase the amount of glucose in urine. And when you're removing the catheter and urine is sugar rich, it's a very common understanding that the risk of urinary infection will be there and you have to be careful about it. Next thing is, does the patient has bladder infection? How will you know this? Is there a possibility of bladder infection at this point of time? Just look at the tubing of the urobag or the urobag itself before you remove the catheter. Is there a pyuria in the urine? The urine will look turbid, creamy white. In this patient, when you remove the catheter, risk of recurrence of febrile UTI is huge. So you have to make a record of this finding. Second, is there a phosphaturia in the tubing of the urobag, the phosphate crystals? Or is there plenty of phosphate crystals in the urobag? If you see this, then you can expect a greater possibility of encrustation of catheter tip. And even if you deflate the balloon, you may find it difficult to remove an encrusted catheter. Third, is the urobag looking purple? And this is called purple urobag syndrome. And this shows chronic urinary infection. And when you remove this kind of assembly of catheter and bag, the risk of urinary infection will be high. So you must make a record and a mention of this finding. The third thing about the patient you need to know is that is there a possibility that in this subject there is some illness which predisposes him to the infection. Say for example, the person may be an immunocompromised host on account of lymphoproliferative disorders, radiotherapy, advanced cancer, advanced age, AIDS. So if you remove a catheter in such a man, you keep him under observation for longer duration and you be more watchful of post-catheter removal urinary sepsis. Then a group of patients can have their urinary tract is compromised on account of having a pre-existing obstructive urinary disease like a stone up in the kidney causing hydronephrosis, or a PUG obstruction, or a reflux, or even adult polycystic kidney diseases. Now, in every of these situations, when you remove the catheter and patient has one spike of fever, the disseminated bacteriuria in the entire urinary tract can settle in the kidney and can become a long duration problematic urinary infection for subsequent doctors to treat. And thirdly, the third part of checklist is to know some general features of that particular situation. For example, are there caregivers along with the patient or not, or some attendant or some family member? Never remove a catheter in a patient who has come alone for this, because once the catheter is removed, after removal of the catheter, certain things have to be watched and patient himself cannot watch all those things. The attendant or the caregiver needs to do that. Second thing is about the timing of removing the catheter. If the patient has come to you in the late evening, never remove his catheter, because if something goes wrong in the middle of the night, the management of the problem will be difficult. or the patient goes home and comes back to you again in the late night with some problems. So I would suggest that as a general clinical principle, remove the catheter early in the mornings. And third thing is, please, if you notice any of the problems that I just spoke to you about the catheter or about the patient where you expect some infection popping up in the waiting in period, you pre-inform the patient that such a thing can happen and he may even be required to be in hospital, right? So this should be informed to the patient and the caregivers, and then only you think of removing the catheter. So I hope you have understood the value of pre-catheter removal checklist, which comprises of information in these three areas: catheter related information, patient related information, and some general information. And please tick everywhere, tick, 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 and only when your checklist is complete, proceed with the catheter removal. I hope you have found this information useful and meaningful. In case you have any questions or comments, please post me on my email. Thank you very much for your patient listening. And in the next video, we'll talk about considerations which you face during the actual removal of the catheter.